Let's start the year with a few tips from Twitter. Hello and welcome to this week's Urgent Bite, brought to you by the Royal New Zealand College of Urgent Care. My name is Guy Melrose, and today we're taking a quick look at a few little tips I've come across whilst browsing Twitter. So first up was a tweet from a Dr. Sarah Edwards, an emergency department doctor from Leicester in the UK, who tweeted a picture of her poster, which had won the best poster from the Association of Paediatric Emergency Medicine last year. Having identified that 25% of children with upper limb fractures were not having their neurovascular status documented, she devised an infographic based on the game Rock, Paper, Scissors. This is an ingenious little aid memoir which they placed on posters and also as a stamp for the notes, and they educated staff to use it to quickly check and document the neurovascular status. Making a rock tests the median nerve, paper tests radial nerve, scissors tests the ulnar nerve, and the OK sign tests the anterior interosseous nerve. Using this quick technique, neurovascular documentation reached 99%. So check out the retweet to see her post and the paper, complete with the references. Next we have a couple of little tips courtesy of Dr. Rob Gregg, the Jersey-based emergency department consultant whose tweet about drawing on dressings to indicate the direction of removal for flap lacerations featured in a podcast last year. Another little tip that caught my eye from his feed was placing a dry tea bag inside a surgical mask to eliminate the odour released when incising abscesses. Now this might not be an issue for some of you, but for those of us who seem incapable of preventing these odours permeating the nasal passages, this tip might well help prevent that reflexive gag we have to stifle soon after we make the incision. Now, despite being an Englishman whose circulating volume is approximately 80% tea, I would certainly sacrifice a tea bag to make this experience less nauseating. His next tip, excuse the pun, is for those fingertip wounds which have avulsed a piece of fingertip flesh and left a bed that is oozing blood constantly. He suggests a pot with 10 ml of 2% lignocaine and 1 mg of adrenaline into which the patient places their finger for 5 minutes. The result is pain relief and hemostasis, allowing the wound to be cleaned and then a dressing of Mepitel to be applied. Some people might question adrenaline use in fingers, but this is only a topical application to the exposed capillary bed. This is also obviously not something to do with more significant wounds, but it's for those little tip wounds like the sort you get with a chef's mandolin. Let us know if any of you have tried this trick. For these sorts of wounds that won't stop bleeding, I've often seen and used Caltastat or a similar brand, which, whilst effective, can be a real pain to remove the next day. So this might well be a better way of managing these bleedy wounds. You can find both his tweets retweeted on our college page. And finally, this last tweet is from a Dr. Christina Johns, a paediatric emergency physician in the United States. This is less a clinical pearl and more a comment on those consultations that end without the need to prescribe, test or provide the patient with anything more than advice. She posted a picture of a speech bubble that says, "Just because no tests were performed or medicines prescribed, it doesn't mean that you did not get care." Now this tweet caught my eye shortly after having had a corridor chat with a colleague who had had a parent complain that they had done nothing for their child. In fact, this doctor had performed a thorough exam, building on a thorough history, which built on a full triage by the nurse and a full set of observations. They provided a diagnosis and advice for how this ailment will run its course, and safety netted the consultation with advice on what to look for should things deteriorate. The inference that they had done nothing because they were not given a prescription or they had no tests done is sadly a common complaint, one I find happens more frequently with increasing wait time and especially if the patient has paid for the consultation. It is frustrating and can be quite demoralising, particularly on a busy shift. That a patient has paid for a consult or waited time to be seen does not change their clinical picture or diagnosis. The effort to take a history, examine a patient, formulate a diagnosis, consider differentials, educate the patient, and safety net the consult, thinking all the time about what you could be missing or am I doing the right thing, is not as easy as it might look to a patient with no insight into what our job actually entails. But when you get this kind of comment or suggestion, you're certainly not alone, and it probably means that you've actually done a good job for your patient, prevented an unnecessary prescription, and not succumbed to poor antibiotic stewardship in the name of speeding up the consult and giving your patient what they think they need. So my thanks to the 3 doctors whose tweets I have mentioned above for sharing these little tips and tricks that I hope might help improve your practice. I've retweeted the originals so you can all find them on our college Twitter feed at RNZCUC. If you don't have a Twitter account, it might be worth signing up for one, as you will find a big community of medical professionals sharing all the latest papers, clinical gems, case histories, images, as well as conferences and job opportunities. If you don't have Twitter and don't want to sign up, simply click on the bird icon at the top of our college webpage and you can still see the college feed and read all these retweets. Now, if you have any comments, questions, suggestions or corrections, email podcast@rnzcuc.org.nz. We'll be back again next week with another podcast. I look forward to seeing you all then, but for now, thanks for listening.